America's aging crisis. A system built for survival, not longevity. For over a century, medical advancements focused on acute survival: antibiotics, emergency care, trauma surgery. This approach worked. Life expectancy rose, and millions lived who otherwise wouldn't have. But this success created a new problem. We built a healthcare system for emergencies, not for the realities of aging. The shift is now unavoidable. The impending demographic shift: by 2030, every baby boomer will be over 65, making 1 in 5 Americans retirement-aged. The fastest-growing demographic is those over 85, the group most likely to require daily assistance. This isn't a future crisis, it's already happening. The system is unprepared, and the consequences are becoming clear. The broken model: treating symptoms, not the condition. Hospitals excel at acute interventions, stabilizing fractures, treating infections, managing crises. But patients are often discharged back into the same fragile conditions that landed them there in the first place. What older adults actually need is coordinated, continuous care, monitoring, in-home support, medication management, and addressing loneliness. The current system treats illness, it doesn't support aging. The hidden economic and emotional toll: families are often financially and legally prepared for death, but rarely for the decade before it, the most challenging period. They underestimate the fragmentation of care, the time commitment of caregiving, the emotional strain, and the escalating costs. Unpaid family caregiving represents an estimated $873 billion annually, 3% of U.S. GDP. Over 53 million Americans provide this care, often at their own emotional and financial expense. The burden falls disproportionately on women, who are more likely to reduce work hours or leave careers entirely. This means the gaps in aging care are being filled by women's time and opportunity costs, a silent economic drain. Aging isn't just a medical issue. It's a life problem that destabilizes families, strains marriages, interrupts careers, and introduces grief long before death. These costs aren't on medical bills, but they often break families first. The systemic failure: longevity without infrastructure. We celebrate longer lives, but longevity without adequate infrastructure is a strain. Hospitals were built, not homes designed for aging. Specialists were trained, not care integrators. Insurance products were created, but not comprehensive care pathways. We built cures, but not continuity. Now, we're surprised by the consequences. The budgetary reality: aging and healthcare costs. As the population ages, healthcare spending isn't just rising, it's reshaping the entire system. Federal spending on programs for older adults, Medicare and Medicaid, is projected to increase from 6.6% of GDP in 2020 to over 9% by mid-century. This isn't waste, it's demography. Older adults use more care, more often, with greater complexity. Costs double between the early 70s and late 80s, reflecting multiple chronic conditions, polypharmacy, cognitive decline, and the growing need for daily support. The current system wasn't designed for this level of complexity. It was designed to intervene, not accompany, to treat, not support, to bill, not follow. The path forward: a shift in prospective care models must follow people over time, integrating medicine, mental health, caregiving, and family support. Policy must focus on the long, predictable period of decline, not just death and disability. Most importantly, we must stop pretending an emergency-focused system can quietly transform into one capable of supporting long lives. The question is no longer if America is aging, but how we will respond. Will we continue to treat aging as a series of medical problems, or will we recognize it as a complex human transition that requires foresight, coordination, and dedicated care? The caregiving crunch is here. Without intentional aging infrastructure, families will continue to bear a burden the healthcare system was never designed to hold.